Hi, I'm Patrick Ryan, and I'm thrilled to be kicking off the OHDSI 2020 plenary session, Large-Scale Network Phenotype Development, Evaluation, and Characterization. I want to remind you that this session is live. All of the presenters are actually available and ready to answer your questions. In the top right-hand corner, you'll see an open Q&A chat session. If you type a question there, I'm here to answer you. You're going to be listening to our presentations, but we really hope that we're going to be engaging in a conversation with you as these presentations go on. I'm joined by a distinguished panel of presenters. Anna, Gowtham, Anthony, Talita, Dani, Noémie, each will be presenting what I think is really groundbreaking work, and it's been an honor for me to be able to collaborate with them in this endeavor. Before we dive in to the innovations and the progress that we've made this year, I think it's worth taking a step back to think about where the community is at large. We all aspire to generate high quality evidence from observational data, and we typically follow a pretty standard process. We try to curate data from a population. We try to select the cohorts that represent the patients of interest. We implement some sort of analysis, and then we try to disseminate the evidence that we generate. And it's usually about that time that we disseminate the evidence that we are challenged with the question, is that evidence reliable? And if we try to author a paper and submit to a peer review journal, we can expect to receive the typical types of questions that come back on all observational research. Questions about whether or not our methods are biased. Questions about whether there's measurement error in our cohort selection process. Questions about data quality. And these questions really underscore the challenge that observational data faces in being a valued resource to generate reliable evidence that can meaningfully inform health decisions. This has been particularly underscored this year in the COVID-19 pandemic, where we've seen lots of well-intentioned researchers attempting to generate evidence, and yet lots of counterpoint arguments being made about whether or not that observational evidence was truly credible. Rob Califf, Adrian Hernandez, and Martin Landry published this perspective piece in JAMA earlier this year, entitled Weighing the Benefits and Risks of Proliferating Observational Treatment Assessments, Observational Concavity, or Randomized Harmony. And in this piece, they argue that given these challenges of observational research, there's the potential that the observational research community may be doing more harm than good, and that potentially our solution needs to be doubling down on conducting randomized trials rather than dealing with the noise that is coming from observational studies. I'd like to posit an alternative title to this presentation. I'd like to suggest that there has been a scientific cacophony going on in 2020 and a real challenge in how we generate reliable evidence, but that harmony can be achieved through collaboration, not merely randomization. This really is the motivation of why we're here together as an OHDSI community, and what I'm thrilled to be able to present for you is the progress we've been making that I think can get us to a point where we really can be confident that we are generating more good than harm. First of all, let's step back to think about OHDSI's approach to observational research. When we curate data, we're looking across a network. When we select cohorts, we're thinking about that within that network. When we implement analyses, we're implementing analysis across our network. And when we disseminate evidence, we are disseminating evidence from that entire network. And we've made tremendous progress towards trying to make this process more reliable. We've done that by developing standardized processes in the data curation and the analysis implementation phase. For example, data curation. We've worked tremendously hard as a community to think about the journey from source data to standardizing the data to the OMOP Common Data Model. We've developed various open source tools and developed workflows and processes that help us evaluate how well we're doing. We've been training organizations around the world on how to follow this process to ensure a consistent high quality result. Just last year at the OHDSI Symposium, when being in rooms together was a thing, Claire Blackader presented Data Quality Dashboard as a tool to ensure the quality and integrity of our data curation process. We've also developed standardized processes for analysis implementation within the OHDSI community. We've thought about the workflow that goes from the question to the evidence and all of the steps necessary to make sure that that is transparent, reproducible, and reliable. Just last year at the OHDSI Symposium, when attending meetings in a room was a thing, Martin Schumi presented the workflow for our population level estimation work and highlighted how this process can be demonstrated to generate reliable evidence. Within the OHDSI community, we've developed standardized processes for patient-level prediction to develop and validate models. Back when meetings were a thing, the women of OHDSI presented at last year's 2019 symposium and showcased this patient-level prediction model in action, developing reliable evidence about breast cancer. Not only have we developed standardized processes to improve the reliability of this process, but we've also established empirical diagnostics that provide us evidence about each step along the way. The data quality dashboard giving us evidence of the data curation process, and study diagnostics providing us information about the rigor of our estimation and prediction studies. But we're still faced with the question, is the evidence we generate reliable? And we're still left with the challenge, what about our cohorts and the risk of measurement error? To think about that problem, we need to level set on some definitions. George Ripsack published a paper a couple years ago in JAMIA defining high fidelity phenotyping. And he described that a phenotype is a specification of an observable, potentially changing state of an organism. The term phenotype could be applied to patient characteristics inferred from electronic health record data. And the goal is to draw conclusions about that target concept based on the raw EHR data, claims data, or other clinically relevant information. And that phenotype algorithms, that is an algorithm that is to identify or characterize phenotypes, may be generated by domain experts or knowledge engineers or through diverse forms of machine learning to generate novel representations of the data. Now in OHDSI, we've defined the term cohort to be a set of persons who satisfy one or more inclusion criteria for a duration of time. And a cohort era is a continuous period during which a person has satisfied a cohort's inclusion criteria. So a cohort definition is a specification for how to identify a cohort. Importantly, based on our definition, a code set is not a cohort. Instead, we need the logic to incorporate a code set into identifying the rules that will govern whether or not a person qualifies for our population. Now, we've developed a tool to allow for the development of cohort definitions and specifications of these cohorts. We use our open source Atlas tool as a mechanism to generate these specifications. And we can create a cohort definition based on an idea of a phenotype so that we can instantiate a cohort against an OMOP Common Data Model database instance. So if we had an idea for a phenotype like type 2 diabetes, we could express that idea in words, the clinical notion of what that disease means, its initial presentation, how it is assessed, a treatment plan, and a prognosis. But we can take that clinical idea and we can implement that into a cohort definition by applying some sort of specification for how do we find the people who have type 2 diabetes. And it could be as simple as saying, well, we'll just find people with a condition for type 2 diabetes. But to answer that question, we have to go back to how do we identify the codes that are going to build up the cohorts that are going to be part of our specification, and how do we evaluate that once we have a cohort, that those patients in that cohort are actually the people who meet that target idea that we're intending to model. Today's session is all about OHDSI's innovations to further strengthen the reliability of observational research workflow and evidence. And I'm really excited about many of the innovations you're going to see here today. Anna is going to show you how we have developed a standardized process to develop phenotypes in cohort definitions. You're going to be introduced to cohort diagnostics, an empirical tool that allows us to take cohort definitions and use descriptive statistics to understand whether or not we have confidence in those populations. Gowtham's going to introduce you to the OHDSI Phenotype Library, an open repository of cohort definitions that have gone through this standardized process. Anthony is going to introduce you to Odyssey's newest standardized process for one of our analytic use cases, large-scale characterization. And then you're going to hear 3 amazing presentations from Talita, Dani, and Noémie about how we've taken large-scale characterization and applied it to important clinical questions about COVID-19 and gender and racial disparities. We're still left with the question, is the evidence we're generating reliable? Well, I hope you enjoy the journey of this plenary session and hope that at the end of this, you can see the progress we're making and hopefully can reach an affirmative answer that indeed we are generating reliable evidence that can improve the health of the patients that we serve. So without further ado, I'd like to hand it over to Anna, who's going to walk you through the journey to standardizing the process for phenotype development and evaluation.
Thanks, Patrick. So I'm Anna Ostropolets. I'm doing my PhD at Columbia University, and today I'll walk you through the concept prevalence and design diagnostics. So as we mentioned, a lot of the studies published out there rely on one single database to produce their results, and that's they develop their phenotypes based on that single database. And what we do in Odyssey is network studies, because we have rich data that we want to leverage to get more people to study more various populations and to produce more reliable evidence. Apparently, network studies have their advantages, but still it makes it really hard to create a good phenotype, because now you have to account for all those different types of data, different origin of data, and so on and so forth. So the very first step in trying to figure out how to design and create good phenotypes for a network study is actually to understand what's going on in the network. So that's why we launched a concept prevalence study. And we started with this simple question: can we characterize data sources in the Odyssey network? And then, of course, we created a protocol, we asked people to participate, and we created a really simple R package that everybody can just run on their instance. And what this package does is it basically counts the records in every OMOP event table, record its domain, and the record count. And we really do not collect any patient level information, no patient counts, no counts less than 100. And that's a really simple algorithm. So that's basically just one line of code per table, and really simple table that you have. So with this simple table with only 3 columns, can we find something really interesting? So we collected the data from 22 data sets from 6 countries. And this data set is probably the largest data set of observational data that exists at the moment. And it has more than 300 billion records and more than 1 million of distinct concepts. And yet this is just a small proportion of the data sets, so that's less than 15%. So even with this small proportion of the data sets, we still found some interesting insights. And I won't be able to go through all of them. I will just focus on the main 2 implications that have consequences on phenotype development. So what you have here is the graph that displays the number of concepts on the y-axis and the number of data sets where these concepts can be found in on the x-axis. And what you can see is that actually a lot of concepts are unique to one data set. And what that means is that whenever you see a concept in your data set, it doesn't necessarily mean that they can also be found in other data sets, and vice versa. If you simply do not see something in your data, doesn't mean that these concepts cannot be found in the other data sets. And what is striking is that even the common concepts do not appear in the all data sets. So here you have a similar scatter plot with a total number of concepts and the number of data sets where they can be found in, and each dot represents a concept, And you see that there are some pretty common things like blood pressure, hyperlipidemia, essential hypertension, which you would expect to see in every database, and yet they are not existent in some of them. So that's crucially important to actually understand what concepts can be found in what data sets. And the second interesting finding is that databases have different levels of granularity. So that means that the representations of the same clinical idea differs in different data sets. And for example, let's take a look at the kidney disorder, and you can see that here there is a database that has a huge number of the concepts that are broad, like renal impairment. And then there are databases that have a very specific, nice concepts that you oftentimes want to include in your concept set. So that's important to understand that there is a different level of granularity between the different databases, and that's why you have to account for it to make sure that you capture all the necessary level of details, depending on the level of detail of the database. And also, what is interesting is that on the average, US sources are more granular than the international sources, and US claims are more granular than EHR sources. And there is this whole discussion about the granularity of the sources going on in the literature, and yet it hasn't been shown that EHRs are more broad than the claims. And the different granularity can be attributable to different coding practices. And what we have in OHDSI is a huge space of vocabularies. So we have more than 150 vocabularies across multiple domains with more than 9 million concepts. So that's a huge concept space. And this is why it's hard to just navigate it properly. So given all the semantic space and heterogeneity of the data, and the fact that most of the concepts can only be found in one data set, how do we even start to create a phenotype? How do we find the proper starting point from this extremely large number of concepts? So let's take a really simple example, diabetes. Where do we start? So we can go to Athena and simply type diabetes type 2 into the search string. And you can see that there are 59 items returned just by this simple query. But we can try a different approach. Let's type 2 diabetes mellitus. And now all of a sudden we have 500 concepts that we have to choose from, and they're totally different. And we can go even further. We can change the spelling one more time, and now we have 160 concepts that again are different. And we have to choose from this whole space. We don't have one single starting point. So, but even if we got the starting point, how do we go about selecting all the concepts that are relevant with all the number of vocabularies and the huge space of concepts? How do we make sure that we included all the necessary concepts and excluded things that are relevant? And that would be actually nice to have a pipeline that would guide you in the process of creating the concept set, modifying the concept set, and evaluating the concept set. So first, luckily, we have it. So let's start with the starting point. And taking the same example of diabetes, we will select a starting point being type 2 diabetes mellitus. What we will do next is we will check out all the descendants of this concept because we think that are relevant. So what we want to do is select all the descendants and go through them and make sure that they all make sense. We feel good about those concepts because all of them mention type 2 diabetes mellitus, and it seems that they make sense. So we will go to include them as well. The next step is to get all these descendants and check out their parents. And sometimes you will see that there are concepts that you might want to include, like renal disorder due to type 2 diabetes mellitus, But there are also others that you don't want to include, like chronic kidney disease. So at this stage, you will get all the parents and you will scroll through them and will make a decision whether to include or not to include them. The next step will be to check in the descendants of those parents that you found. And again, you want to make sure that you capture everything that you think is relevant to your clinical idea. So we selected all the descendants, and again, here they make sense. We created this concept set that still belongs to the kind of same hierarchy. And the next part will actually be the hardest part, because now you have to check all the other concepts that are located in different places in hierarchy and are disjoint. And there are two parts to it. The first one is you want to capture all the standard concepts. And the second part is that you also want to make sure that all the relevant source concepts are included. So you want to check, for example, ICD-10 and ICD-9 and get their standard counterparts and include them in your concept list. And that probably would be the hardest one because there is no hierarchy to guide you. So at the end, you have this set and you iterate until you get a comprehensive one. You iterate until you feel good about the space that you selected to represent your clinical idea. So we developed this algorithm, which starts with picking the initial concept, then reviewing and adding descendants, then reviewing and adding all the parents that you haven't included, reviewing the lexically similar concepts from the other places in the hierarchy, and reviewing and removing the included concepts and making sure that you haven't included anything that is irrelevant. And then you create the concept set and repeat the process until you feel good about your concept set. And this algorithm is a nice, good algorithm, but yet we're dealing with vocabularies that have more than 9 million concepts. And within this space, it would be impossible to actually fully run this algorithm unless you have something that provides you an information about what's going on in the data and whether you can see those concepts in the data. And luckily enough, we created such a tool that will guide you through the initial concept recommendations and through the concept set recommendations so that you can iterate, include and exclude concepts and see which concepts exist in the data. And we called it PHOEBE. So now I will walk you through it and how you can use it. So here's PHOEBE sitting on the data.odyssey.org. So let's start with the initial concept, for example, diabetes. So first, we would like to specify our domain, which will be condition. And then the starting search string, which will be type 2 diabetes. And what we get as an output is one single row with all the attributes, concept ID, concept name, vocabulary ID and domain ID, and the record count across the concept prevalence set. So we can see that this concept alone has about 1 billion records, and it can be found in almost every database in 21 out of 22 datasets. And with the descendants, this concept has even more records. So that's now 1.3 billion records. But let's try out different approaches. Maybe changing the search string will give us a different result. So let's, for example, modify it to a different spelling. And yet what we see is the same starting point. And if we want to be explicit, we can do diabetes mellitus type 2, changing the word order, being explicit. And we yet get the same one single string instead of a huge amount of concepts that you would get otherwise. So this will be the starting point, and let's save it for later. But this tool can also work for the other domains and for the other conditions. So let's try it out for a different example. The one that I like a lot, because it so happens that I do some research in it, is the deep venous thrombosis. And when you click on that, you again get one single concept instead of 1,000. And what is interesting, that this concept, first it has a different spelling, because we use concept synonym, we were able to actually capture this concept. And the second one, that here there is a huge discrepancy between the record count and record count with descendants. So what that means, that this verbatim concept can only be found in the 7 data sets and only has 450,000 records. But when taken with the descendants, it appears in all of the data sets and has a higher number of records. So now when we have a starting point for diabetes, let's actually resume our process for the concept set. And let's go to the concept set recommender. So now when we have the initial concept for our diabetes, let's explore the recommendations that we have for it. So what you have in this table is the recommendations and the category that explains why those recommendations were made. So either it was a descendant or a parent or recommended concept. And then you have all the attributes like concept ID, concept name, and so on and so forth. And you have the record count and the database count, and the list is prioritized based on those numbers so that you get the most common concepts on the top of the list. And for the starting point, we got 116 entries. So now let's take a look at those categories. So the very first one is the included concept. And of course it looks nice, so we'll take it. The next category that we want to explore are the descendants. And we want to spend more time on the top rows because they have more data in the databases. So the very first one is diabetes 2 without complications. Looks good. And in the following manner, I'll go through all the descendants. The next category that we want to explore is the parent category. And here you have one concept, diabetes mellitus, which is not specific and might include type 1 and type 2, but yet this verbatim concept occurs in 18 databases and has a huge number of records, more than 23 million of records. So seeing this data, you can now think about whether to include this concept or not. And we do not advocate for including that or for excluding it. What we are saying is that now you have a tool to make this informed decision on your own. And finally, there were recommended concepts. And we got this first one through the descendants, so we'll check out the next one. And that's disorder of the nervous system due to type 2 diabetes mellitus. And that's recommended via source concepts. So if you want, you may also want to explore the source concept for it. So I did this whole process for all of the concepts, and I actually think that all of them make sense, and I want all of them in my concept set. So what I will do next is I will copy all the concepts IDs and I will paste them in and do the second iteration. Having this list handy, copy in. So let's repeat the process for our newly created concept set. So we have the included concepts. We already take a look at them. We don't want to do that again. So the next thing will be to check the descendants again. Okay, so type 1 diabetes is something different from what I want, so I will not include that in my concept set. Secondary diabetes, I may debate about because I'm actually not sure whether to include it or not. I probably don't want gestational diabetes, but then I have a concept that look appealing. And diabetes mellitus without complication is a nice concept that I may want to include. And it appears in 19 databases with a record count of more than 8 million records. So I really now want to consider if I want to include this concept in my concept set or not. And the next group will be parents again. And I will check, I probably don't want chronic kidney disease. I don't want kidney disease again, but there is this concept of complications due to diabetes mellitus, and this one I definitely know. And there are other things that I might want to include, especially given that they're common and prevalent in the databases. And in the similar fashion, I would explore the suggested recommended concepts. And I will see a lot of them that look similar to the standards of parents, so I will not include them again. But there is this concept diabetic and insulin, which I again may think about including. So I will iterate on this concept list over and over again, paying more attention to the top concepts because I know that this is where the data is loaded on. And then after I iterate to the point where I feel confident about my concept set, I will stop and create a cohort with the concept set that I just made. So going back to the presentation, now with this concept set, we can create a cohort, which is the first occurrence of any concept within this concept set. And I walked you from the very beginning, from starting your concept set, all the way to refining it and creating a cohort with it. And now we want to make sure that this cohort actually finds us the patients that we want to be included in the study. And with that, I will turn it over to Gowtham, who will explain how to use data diagnostics to make sure that you got the right patients.
Thank you, Anna. I am Gowtham Rao, Senior Director of Epidemiology at Janssen R&D, and I'm going to talk about data diagnostics. Anna has given me 2 cohorts based on design diagnostics. These 2 cohorts represent the phenotype of type 2 diabetes mellitus. Before we go deeper into data diagnostics, we need to ensure that we understand the clinical ideas behind type 2 diabetes mellitus. This is one clinical description of type 2 diabetes mellitus. When we read this, what we see is that it describes the generic use of diabetes mellitus to almost always refer to type 2 diabetes mellitus. We also see that most commonly, patients are diagnosed using a screening test, and they're asymptomatic at the time of diagnosis. Some people got diagnosed in emergency care settings, where they present themselves with hyperosmolar hypoglycemic state. The description gives us the common tests that are performed for patients with diabetes mellitus, such as hemoglobin A1C or even liver function tests. It says that metformin is the most commonly dispensed drug as first line, and that this disease is a lifelong disease. Reviewing this clinical description gives us a shared understanding of this phenotype. We can now apply a suite of data diagnostics on the 2 cohort definitions that Anna has passed to us. We define data diagnostics as a set of descriptive statistics that provide insight on the performance of multiple cohort definitions when applied across the data sources. For example, we have cohort counts. This is the number of unique persons per cohort in each database. This is useful because it indicates the magnitude of difference between the definitions. For example, does one definition yield more or less people compared to another definition? Does that difference between the core definition hold the same across all the databases in the network? Or is it just an anomaly of one database? is the difference in count significant enough, big enough that this definition changes actually matters? Incidence rate. In this diagnostics, we review the occurrence of disease across gender, age, and over calendar years. This is useful because most diseases that we study, we have some baseline expectation. Like for diabetes, we expect higher incidence rate among older individuals compared to younger individuals. We can check this in the data. Time distribution. This reports to us the distribution of observation time before and after the index date. Do we have sufficient time of follow-up for our exposure cohorts? Index event breakdown. This shows the concept or concepts that likely triggered the entry of a person into the cohort definition. Visit context. Visit context shows the types of visit that occurs around the index date. For diabetes, we read that most common diagnosis for new patients is through a screening test. And this probably happens in an outpatient setting in a doctor's office, while a small minority are diagnosed in the emergency room. We can test that in the data. Overlap. Cohort overlap helps us compare two different cohort definitions to see how many people met the cohort definition in one, met the entry using one cohort definition or both cohort definitions. Temporal characterization. Temporal characterization tells us characteristics of the people in the cohort as of the index date, or sometime before the index date, or sometimes after the index date. Thinking about the type 2 diabetes mellitus, we expect patients who are newly diagnosed with diabetes to start a drug like metformin after the diagnosis. We generally don't expect diabetic regimens like insulin to occur before the first diagnosis. Now, let us go and see this data diagnostics in action on the two cohorts that Anna has given to us. The first cohort is a cohort of people who are newly diagnosed with diabetes mellitus for the first time in their history. Incident diabetics. For this definition, she used type 2 diabetes mellitus, the SNOMED code of type 2 diabetes mellitus, and its descendants. She also required them to have at least 365 days of observation prior to the index date, and this code had to have occurred for the first time in the patient's history. When we look at this concept set expression, we resolve it, we find that it has about 17 SNOMED codes and more than 100 source codes. These source codes belong to various vocabularies such as ICD-10-CM, ICD-9-CM, and read codes. Anna has given us another cohort definition, and this cohort definition is also an incident diabetes cohort definition, but its concept set expression is different. This concept set expression came from the recommender system. When we look at this concept set and we resolve it, this concept set has 11 SNOMED codes, and when we resolve it, we see that it has more than 400 SNOMED standard codes. When we looked at the mapped codes, this particular expression resolves to more than 2,000 source codes, also of the various vocabularies. Now let's start the diagnostics by looking at the cohort counts. Here we have cohort counts across one database, the IBM CCAE database. In this table, the first row is the initial cohort, and the second row is the cohort that was recommended as part of by the recommender system, the C4 cohort. What we see in this database is that the number of people that met the criteria has increased from 1.9 million to more than 3 million, about 30% increase. Now let's look at another data source, another US data source, the Optum Extended DoD data source. In this data source, we also see an increase from 2 million to about 2.5 million, about 10% increase. Let's add another data source from Japanese JMDC data source. In this, the count has increased from 120,000 to 290, more than doubling. And European data source, like the IQVIA Germany disease analyzer, here the count went from 905 to more than 10,000, a 10-fold gain. Across all of these data sources, we are seeing a pattern that the cohort that is created by the recommender system has significantly more number of people compared to the initial cohort. Now let's go through another set of diagnostics. This is the incidence rate diagnostics. In this plot, we see on the y-axis the two cohorts that Anna gave us, the C1 cohort and the C4 cohort. On the x-axis, we see various calendar years that are in the data. Each column represents an age strata, and the colors represent gender, with the blue being male and the red being female. We know that diabetes, we know by reading the clinical description of diabetes, that the incidence of diabetes goes up with age, and we observe that in the data. We also observe that the incidence is higher among males compared to females. And this is along expected lines. But what is interesting here is this unusual spike in the year 2015 in one of those definitions. Now let's add another data set, the JMDC database from Japan. In this database, we continue to see those things that we expect: increased incidence rate among males, increased incidence in older individuals. But we don't see that spike that we see in C1 definition on IBM CCAE. What is interesting to observe here is that the cohort that was built using the recommended system does not have that spike. It seems to be more stable, and it is more stable and seems to be more reliable even in the JMDC database. So based on these two diagnostics, I think we can conclude that C4 seems to be more appropriate and more stable compared to the C1 definition. This next diagnostics is the temporal characterization. What you see in this table are characteristics of the cohort at various time periods in relation to the index date. The covariate, the first one on the top, is diabetes mellitus without complication. What we see is this covariate is present in 72% of the people on index date. That's expected. But what is interesting is that this code is only present in about 18% of the people in the first month after the index date, and repeats only about 35% of the time about the people in the 1 year after the index date. The second covariate here is a measurement. This is hemoglobin A1C. This is interesting because we see that about 36% of the people had an hemoglobin A1C testing on their date that they got diagnosed with diabetes. That is expected. We expect that people would have a diabetic test on the date that they got diagnosed. But what is also interesting is about 15% got diagnosed in the month prior. This is explainable because some of these people may have had a test and then they came back to the doctor's office for a review, and on that day they got diagnosed with diabetes. But what is suspicious here is this 26% in the 1 year prior to the index date. Suspicious because I would wonder if this is actually patients who are already diabetic. They're prevalent diabetic patients who are having a hemoglobin A1C as part of their care. They just weren't coded to have diabetes. They don't truly represent incident disease. So we need to test for that, and we need to let the data show us. So one way of doing it, we know that metformin is a commonly dispensed drug. Let's see if metformin is the rate of metformin in this group. When we filter on metformin, we see that in the 1 year prior to the index date, about 10% of the people were on metformin. Now, this makes me very suspicious. I feel like our definition is not capturing the index date, and our data is telling that we need to do something else to improve our definition. So how about we need to do something to shift the index date earlier. So we built another definition, and in this definition, we allow the people to index on their first occurrence of either a diagnosis code or a drug that is used for the treatment of diabetes, or a hemoglobin A1C measurement with a value that is greater than 6.5. We require all of the individuals to have the same concept sets for type 2 diabetes mellitus that was recommended by the recommender system. Now let's compare this new cohort definition that the data has informed us to the prior definition, the C4 definition that the recommender system had recommended. Now let's go back to temporal characterization. In temporal characterization, we have selected the two cohorts, the new cohort that we built informed by the data, and the previous cohort, the C4 cohort that was informed by the recommender system. What we see is for the index date, the diabetes mellitus without complication still continues to be the most common covariate, but it is slightly lower at 62% for our new cohort compared to 72% for the prior cohort. This is explainable because now we allow the individuals to enter into the cohort with either a code, a drug, or a lab measurement. So some of these people in that is 10% may have entered with a drug or a code. The second most common covariate continues to be hemoglobin A1C. And what we see is the hemoglobin A1C is still almost as high as in the previous cohort. But what we really want to see is the metformin. We now see that the metformin accounts for about 20% of the people on index date. There is no people on metformin at any time before, by definition. This new definition is probably more precise in identifying the index date of diabetes mellitus. I've just walked you through a process for type 2 diabetes mellitus. We want to follow a systematic process to build cohort definitions. We want to start with a clinical description of the phenotype we want to develop a cohort definition for. This cohort definition has to go through diagnosis and then an iteration to make it better. On each iteration, we want to compare the performance of the cohort definition to its earlier version, or maybe even compare it to an existing version. And while doing so, we want to let the data give us insights. We want to use those data insights to make more iterations. We want to iterate until we feel like our data diagnostics is giving us confidence to use our cohort definition. In the last year, our community has done a lot of phenotype development. Along the way, we have gained experience about the phenotype development process. What Anna and I have just shown you is the distillation of this learning into a standardized process. With the standardized process in place, we can collaborate together and collectively apply the process to build phenotypes effectively. As a community, we can build more phenotypes. If we collaborate together and share our collective work in a consistent way, we can build a community resource that all of us can benefit from. So let me introduce you to the OHDSI Phenotype Library. On the screen, you see 247 phenotypes. Each of these phenotype is identified by a unique identifier, a phenotype ID, a name, and a description. If you click on a phenotype, you get more details. At the bottom, you see the description, the clinical description of this phenotype with the standardized format and overview, a presentation, assessment, plan, and prognosis. We have also created a template for literature review. And in this literature review, we have attempted to look for prior implementations of such cohort definitions. What codes did they use? What was the performance statistics of these published cohort definitions? What was the sensitivity? What was the specificity? What was the positive predictive value? We performed a large number of literature reviews and compiled them in a standard format and have made it available as a resource in the OHDSI phenotype library. Currently in the library, we have phenotypes that start from abdominal pain and ends with Waldenstrom's macroglobulinemia. Those include phenotypes that have been used in prior OHDSI studies, like the OHDSI Legend Hypertension study, that study the outcome of acute myocardial infarction. The phenotypes list also includes prevalent chronic diseases like asthma and atrial fibrillation. We have other chronic diseases like chronic obstructive lung disease and chronic kidney disease. The phenotype library includes phenotypes of symptoms like diarrhea, dyspnea, fever, and fatigue. We have adverse outcomes like hemorrhagic stroke and hepatic failure. The library has rare events like transverse myelitis and narcolepsy. Pregnancy and pregnancy-related phenotypes like preeclampsia and preterm birth. We have outcomes that are attributed to COVID-19, such as pulmonary embolism and respiratory failure. And we have the COVID-19 infection itself. We have adverse events of special interest as prioritized by the Brighton collaboration for COVID-19 vaccines, such as vasculitis and venous thromboembolism. For each of these phenotypes, we have created 2 or more cohort definitions. Some were informed by design diagnostics, some by data diagnostics, and others were from literature review. For all of these cohorts, we have run diagnostics across multiple databases across the OHDSI network, and all of them are ready for community review. What I'm showing you is a publicly available community resource, and I encourage you to go check it out at data.ohdsi.org/phenotype library. I also encourage you to join us in developing this community resource. There are lots of ways that you can help. You can author a phenotype. To author a phenotype, you need a phenotype name, a clinical description, and at least one cohort definition. It's JSON expression. You need to run this cohort definition using cohort diagnostic on at least one database. You can contribute by authoring a cohort definition. You can pick an existing phenotype and build a new cohort definition and give it a cohort definition name, a logical description, share its JSON expression, and run this cohort on at least one database. You can run diagnostic. You may have data and you may want to pick one or more cohorts from the phenotype library and run it on your data source. Or you can contribute by providing us your insights. You can review the content that's already in the OHDSI phenotype library and look at the notes or provide your notes on each one of these cohort definitions. And we have developed these forms to facilitate the process. Please join the OHDSI phenotype workgroup that is currently on the OHDSI Microsoft Teams and contribute, get involved, and join us on this journey. This work is extremely important. It is the one common piece in all our studies. It is the pillar that is necessary to ensure reproducibility and credibility for our science. It is the journey that precedes all other journeys. I am personally very excited to be part of this work because I and others who worked on this truly believe that when we get this right, we will change the way we do observational data science. Thank you for your attention. Let's now take a quick OHDSI energy break. And when we return, Anthony Sena will give us the framework for large-scale characterization.
Hi, my name is Anthony Sena, and I'm going to be taking you through a framework for large-scale characterization. Before we dive into the large-scale characterization framework, I'd like to start by taking you through some of the innovations and insights we've gained during the course of OHDSI's open source development. This journey starts with cohorts and its development led by Chris Knoll. A key innovation here is the notion of standardized cohort specifications with a fully specified set of inputs to define a population of people that satisfy a set of criteria for a duration of time. Cohorts are the cornerstone to OHDSI study designs. Next innovation makes use of cohorts to construct baseline features for all persons across all clinical observations. This development, led by Martijn Schumi, allows us to construct and aggregate cohort features at scale. Cohort method brought forward a standardized framework for the design of population-level effect estimation, leveraging cohorts and feature extraction. Marc Chouchard and Martijn codified this standardized framework, and it allows for the generation of large-scale effect estimation as demonstrated in the Legend project. Jenna Reps and Peter Reinbeck applied a standardized framework to patient-level prediction, and a base was the introduction of an interactive results viewer bundled as part of a study package. Atlas's characterization module, led by Chris Knoll and Pavel Grafkin, innovated by allowing for cohort subgrouping and for comparing results across multiple cohorts. Diagnostics, started by Patrick and Martijn and now led by Gowtham, allows us to empirically evaluate a group of cohorts and gain key insights for study cohorts. It also marked the first time an interactive results viewer allowed us to explore results across databases in a single view. P-Evaluator allows for the empirical evaluation of cohorts using predictive models. This work, led by Joel Swerdell, is a novel and innovative way of describing the operating characteristics of a cohort definition. Gowtham about the Phenotype library, which brings together the insights from cohort diagnostics and P-Evaluator to provide a holistic view of a phenotype's evaluation. All of the innovations and insights gained through the development and application of the OHDSI's tools has led us to another innovation, which we've built into our large-scale characterization framework. We make use of the shared repository of inputs from Phenotype library, and we defined and applied a standardized framework to optimize large-scale characterization across hundreds of cohorts, as we'll cover shortly. We've built a results viewer that allows for the comparison within and across cohorts, as well as databases. So let's dive into the framework and see how it works. To start, we'll take a population of people represented in the database, and amongst those people, we can define a target group of people in a cohort that we would like to characterize. Additionally, we can apply another cohort. We'll call that a subgroup cohort. Again, a group of people satisfying a set of criteria for a duration of time. If we take the intersection of that subgroup cohort along with the target cohort, we create a third cohort. This we will call the target in subgroup cohort, or TWS. Additionally, we can apply multiple target cohorts, and they need not be mutually exclusive. People can be in more than one target cohort at a time. And we can apply the same rubric to subgroup cohorts. Again, using the intersection of these cohorts to define other subgrouped cohorts. Applying a similar framework, we can characterize a population using features. If we take the same database and we characterize those people with a particular outcome of interest in red, we can define a target population and count up the number of people with a given feature in that cohort. Additionally, we can do the same operation for a subgroup cohort and count up the number of people with that feature. Finally, we can do the same thing for those members of the target within the subgroup cohort and count up the number of features within it. Using this, we can then apply a time component to look at the interval of times that those features occur within a target population. So let's take this from the perspective of a single person who belongs to multiple cohorts. So in this example, we've taken a patient who is a member of a target cohort, a subgroup cohort, and multiple feature cohorts. We can see that this subgroup overlaps with the target, and the person would qualify for both the target and the target with subgroup cohorts. Additionally, since this person's in the feature cohort and their feature overlaps with the time at risk, this person is going to contribute to the numerator of prevalence. Additionally, they may also qualify for that feature cohort, but if it falls outside of the time at risk, it's not going to be used. So we can use this as a way of defining a characterization study. So our framework consists of target cohorts that we would want to characterize, subgroup cohorts that we could use to find the intersection of people that are in our T cohort as well as the subgroup. We can also use feature cohorts to construct features for characterization for different time at risk windows. So let's see how we might use that framework to scale out cohort construction. So if we take as inputs different cohort specifications for target cohorts and subgroup cohorts and apply the intersection approach that we described earlier, out of that process, we actually come up with 3 different sets of cohorts. We have the original target cohorts that were the inputs. We have the targets with the subgroups, the intersection of those two, and the targets without the subgroup. You can think of these as the stratified versions of these targets without the subgroup. If we wanted to create an example, we could create an example of 3 different target cohorts. Diabetes, hypertension, and depression are our targets. And we have female, Black, young, and old subgroups as our subgroup cohorts. If we take the combination of those 3 targets across the 4 different subgroups, with and without subgroup membership, we wind up with 27 cohorts. We have persons with diabetes in our target. We have persons with diabetes and female, that's our target with the subgroup. Persons with diabetes and not female, those are our people in the target without the subgroup. And we could enumerate all of the different combinations to get the full 27. So we could use those inputs that we created by scaling out the cohorts and use those to scale out the feature construction. So our inputs in this step is to use the instantiated cohorts. Those are the targets with subgroups and target without subgroups, as well as our feature cohorts, as well as any concept-based events we might want to observe during the time at risk windows. The output is producing summary statistics, that is the prevalence of the persons in our cohort with features during a time at risk, divided by the number of persons in the cohort. So to extend our previous example, we have our 27 cohorts that are our inputs, as well as we've defined 5 features that we'd like to characterize, in this case hospitalization, AMI, death, surgery and drug initiation, and 2 time at risk windows, the year prior to index and the year after index. So taken together, there's 27 target cohorts and 5 feature cohorts, as well as the 2 time at risk windows, results in 270 different statistics. And if we enumerate those out, we have our persons with diabetes and a hospitalization feature in the year prior, as well as the persons with diabetes and hospitalization in the year after index. And we can do this for each of our targets and each of our features for each of the time windows. Taken together, we can see that this framework provides a set of inputs in our targets, subgroups, feature specification, and time at risk windows. We can apply the intersection approach that we discussed earlier, as well as the temporal characterization to produce a set of summary statistics across all of these different combinations. The results are assembled for each database and stored in a simple data model, which is then powering our results viewer. So to talk a little bit about how this framework has been implemented so far, we've implemented this in a series of study packages. As part of the best practices that we've learned from our previous development, we've run cohort diagnostics for all of the study cohorts. We apply this large-scale characterization for all of the target, subgroup, and feature combinations across all of the different time windows, as well as we decided to compute all demographics and concept-based features for all time windows. Again, we can review the results via an R-Shiny application locally, And when we provide those results back to the study coordinator, we can see those results across multiple databases in the network. This is an example of the characterization viewer that was used in some of the study packages. As you can see here, we have the different characteristics of the cohorts on the left-hand side of the table. And across the right, you can see the different databases that have contributed their prevalence information for this cohort. On the left-hand side, we can go through and filter and look at different subgroups within that particular cohort, as well as different time windows of interest. We could additionally compare different cohorts using the cohort comparison viewer. Again, using the same characteristics, we can compute a standardized difference of mean across different cohorts or even different subgroups within the same cohort. We can take that standardized difference of mean and plot it here to visually find those characteristics that differ between our target and comparators. So to see how this was used in action, the project CHARYBDIS, which Talita is going to take you through, was our large-scale characterization of COVID-19 disease natural history. And as part of that study design, we used 22 different target specifications, 58 different subgroup cohort specifications, 64 feature cohort specifications, as well as concept-based events, and 4 time at risk windows, resulting in 326,000 summary statistics. When we applied this across 22 different databases, the result was over 286 million results and counting. And you might wonder, how exactly are we going to go through 286 million results? Well, thankfully for us, a member of our community, Kristen Koska, has already volunteered to do this for the next 45 years, as she has now solidified in her meme, which she's contributed to the Beabathon. Some other examples of where we've applied this framework in action is the SCYLLA characterization. So we're doing this in support of the COVID-19 therapeutic evaluation, and Dani's going to talk in more detail about this. As part of this particular study, we used 89 target specifications, 6 subgroups, 64 features and concept-based events, 4 time at risk windows, resulting in 136,000 summary statistics. So far, we've gotten 13 contributing databases with over 27 million results and counting. And finally, the HERA project, which Noémie is going to take you through, is our large-scale characterization of gender and racial disparities. Again, as part of this, we had 132 target specifications, 8 subgroup specifications, 124 features, 3 time at risk windows, resulting in 392,000 different summary statistics. At the moment, we have 5 contributing databases with over 107 million results and counting. Thank you for listening. I'd like to turn it over to Talita, who's going to take you through one of our clinical applications of this large-scale characterization framework.
Hi everybody. My name is Talita Duarte-Salles. I'm an epidemiologist working at EDAP Jordi de Gaulle in Barcelona, in Spain. And today is my pleasure to present the CHARYBDIS project, which is a large-scale characterization study on COVID-19. And before we start, I'd like to thank the OHDSI Symposium organizers to give me the opportunity to talk about this project in the name of the CHARYBDIS team. So starting with the agenda of the project, here's, I will briefly explain a little bit why we're doing CHARYBDIS. I'll then explain the main objectives and methods of CHARYBDIS. I will give a brief overview of the main databases that are participating now in CHARYBDIS, and finally I'll give a very brief overview of the main findings to date. So starting on why we're doing CHARYBDIS, I think that by now it's nothing new that we have this coronavirus disease that started in December 2019 in China and very quickly spread it all over the world. And since this is a new disease, we really need to understand the natural history of this disease. We need to understand the patient trajectories from when a person starts having symptoms to being hospitalized with the disease and dying with the disease. So at the beginning of the pandemic, there were many publications on the characterization of COVID-19 patients that were published in very high impact journals like the New England Journal of Medicine or the Lancet. But the main limitation of these studies is that these studies were based on very small sample sizes. So most of studies were performed in less than 1,000 patients. Most of the studies were performed in China. There were quite a few in Europe and the US. Most of the studies have limited granularity of information, and the majority of studies were performed in hospital settings. So with all this in mind, there were still many unanswered questions. So we still didn't know who were the people that were getting infected and hospitalized with this disease. So we needed to better understand, the demographics, the most frequent comorbidities, the treatment history of these patients. We didn't know what were the main symptoms and outcomes of this disease, and how different this disease was from other viral diseases like influenza. For a global pandemic like this, I believe that it does require a global response, and that OHDSI is the perfect network for this. OHDSI has currently thousands of collaborators all over the world, and a data network of including millions of patients' records. So now I'm going to explain very briefly what are the main objectives of CHARYBDIS. So we wanted to describe the baseline demographics, the clinical characteristics, the treatments, symptoms and outcomes of patients with COVID-19 overall, but also stratified by sex, age, and specific comorbidities. We also wanted to describe the characteristics and outcomes of influenza patients between September 2017 and April 2018 for comparison. And these are the cohorts that we created. So we started with starting with the cohorts of COVID-19. We had a cohort of persons that were tested for COVID-19. We also had a cohort of people that were tested positive, a cohort of people that were tested positive or diagnosed with COVID-19. And then we also had the cohorts of people that were hospitalized with COVID-19 and those that were hospitalized and required intensive services. We then also created 3 cohorts for influenza. So we had a cohort of patients that were diagnosed with influenza between 2017 and 2018. And we had the cohorts of patients that were hospitalized with influenza and those that were hospitalized with influenza and required intensive services in 2017 and 2018. And all the cohort definitions can be found at atlas.ohdsi.org. And we then wanted to understand we wanted to perform this characterization within specific population subgroups. So we created different stratification factors. We wanted to understand better the characteristics of the population with COVID-19, but we also had other diseases like asthma, cancer, COPD, hypertension, HIV, etc. All the definition of these comorbidities can also be found at atlas.ohdsi.org. And as for the main features, what were we describing for this cohorts? We wanted to describe all the conditions and drugs that were recorded during the year prior to the index date or the 30 days prior to the index date. The index date in this case being the date of the diagnosis of COVID-19 or the test or the hospitalization. We also wanted to describe the main demographics, so age, sex, and race when available at the index date. And also we wanted to describe all the conditions, symptoms, outcomes, procedures and drugs that were recorded at index, but also during the 30 days following the index date. The R package to run CHARYBDIS is available at GitHub, and if you have now your data mapped to the OMOP CDM and you want to run CHARYBDIS, this is available here. As for the main data sources, so these are the databases that have run CHARYBDIS so far. So we have 11 databases that have run CHARYBDIS from the US. There are 8 databases that have run CHARYBDIS in Europe, including data from the UK, Germany, Spain, the Netherlands, France, and Italy. And there are 3 databases from Asia, 2 from South Korea, and 1 from China. Overall, we now have access to we have results from more than 7 million patients that were tested for COVID-19. We also have a cohort of more than 1.5 million people that were either diagnosed or tested positive for COVID-19, and more than 300,000 patients that were hospitalized with COVID-19. Now I'd like to explain, just give a little brief overview of the main findings today from CHARYBDIS. So all the results are actually now publicly available at data.odyssey.org in this link here. And anybody can access to these Shiny app results. So here you can see, you have the access to the study protocol here, also to the analytical codes in GitHub. And you can also have access to all the cohort diagnostics for the cohorts that we've created. In this Shiny app, if you want, you can also go in and have a look at the main cohort characteristics of each of the data for each of the databases and cohorts. And you can go on and also compare different populations, different cohorts by database. So as for the main findings to date, I think related to COVID-19, we can say that we've seen that while most of the people that are diagnosed with COVID-19 are most frequently females, the hospitalized population are most frequently males. So you can see in this figure here, we have the distribution by age and sex by database in Europe. On the left, you have the females, and the right, you have males. And in red, we have data from the diagnosed population, and in blue, the data from the hospitalized population. And here you can see the same figures for the databases in the US. And what we can also see here, so in red, we have the data, the results for the diagnosed cohorts, and in blue, the results for the hospitalized population. And what we can see is that the hospitalized are usually older than those that were diagnosed. Regarding the comparisons between COVID-19 cohorts and influenza, what we can see here is that COVID-19 is basically no flu. COVID-19 patients are usually healthier with less comorbidities, and they have less history also of drug use. But at the same time, one thing we can see is that also they have worse outcomes. So for example, here we have data from Colombia, where we can see that those in red, we have the results from the COVID-19 cohorts, and in green, it's the influenza cohorts. And we can see, for example, that the fatality rate among those diagnosed is 6.3 for COVID-19 patients, while we see 0.6 fatality rate among those with influenza. So these are the publications to date. If you're willing to know more about the differences between COVID-19 and influenza, please have a look at Ed's paper on the characterization of patients that were hospitalized with COVID-19, and we have a very interesting comparison with the influenza cohorts there. And we also have these two other papers that are now available on medRxiv, one on the drug utilization used among hospitalized patients, and another one on the characteristics and outcomes of patients with and without obesity. But still, there are many unanswered questions on COVID-19, and we believe that with the results that we've generated with CHARYBDIS, that we were able to help answering these questions. There are many questions on the relationship between autoimmune disease and COVID-19. There are questions related to pregnancy and COVID-19. There are questions on the pediatric population and COVID-19, HIV, asthma, the testing population, who is getting tested, what are their characteristics. There are many questions on the racial disparities, the interventions that are being performed during hospitalization. There are many questions on cancer patients and COVID-19 patients, and we believe that with all the results that we are generating, we'll be able to help answering those questions. And we currently have different groups working on these questions, and if you're willing to get involved, please get in touch with us. Just to finish, I'd like to say that I believe that only a monster can beat another monster, and here's a picture of CHARYBDIS, and I have no doubt that we've created a monster here with the amount of results that we've generated. This is a screenshot of the Shiny app of CHARYBDIS, and you can see the amount of information that we're creating here. And if you're willing to join the CHARYBDIS team, please get in touch with me or with Kristen Koska from IQVIA or Albert Batz from the University of Oxford, who are co-leading the CHARYBDIS project. And finally, I would like to thank all the OHDSI heroes and all the CHARYBDIS team, all the people who've been involved in CHARYBDIS for the last months. Special thanks to Anthony Sena, who has created the R package to run the study. Big thanks to the Phenotype team and the literature review teams for all your support. And special thanks to all the CHARYBDIS study leads and everybody who's been involved in CHARYBDIS for the last month. And now I'm going to leave you with Dani Prieto, who's going to tell you all about SCYLLA.
Hello, welcome to the OHDSI Symposium 2020. I'm going to be talking to you about SCYLLA, a monster that we're going to be fighting together for the next few months. If I have my presentation in. Okay, these are the things that I'm going to cover. I'm going to start by trying to explain to you why we need to do SCYLLA despite all the trials that are going on. Secondly, I will talk about the aims and methods that we're going to be using in SCYLLA. Third, data sources and numbers of participants in the study to date. Fourth, some findings on drug utilization. And finally, a call for participation. First, I know that there are a lot of randomized controlled trials studying many medicines in the COVID-19 pandemic, and there has been some concern with this letter published a few months ago that real-world evidence might be killing or precluding randomized controlled trials. This is a letter that was published in the New England Journal of Medicine and had a long response from many co-authors. So here in Oxford, we have quite a lot of experience with both myths and magic, and in fact, Recovery, which is one of the largest trials, is being run from here. And I just wanted to show you that, in fact, we do have in North Oxford, this area where J.R. Tolkien lived and where he probably wrote most of the parts of the Lord of the Rings and many other myths and magic. I also show you that very close to his home, there are three very interesting locations where some of the main OHDSI battles have happened in the past. You see here in Lady Margaret Hall, where we had one of the Oxford study-a-thons. You see the Cherwell River, where we had an eventful journey together, and finally the Cherwell Boathouse, where we had a great battle and there was a lot at stake. Oh, I'm afraid there's only 2,342 trials ongoing on COVID-19, so we're going to need to justify why we really want to do SCYLLA. So one of the main reasons is that we do have tons of data available and we can explore the effect of medicines given for COVID-19 without exposing patients to any further risk, because all the data we're going to be using, of course, is from the past. We are going to be learning from what's been given to patients. And another key reason is that despite all the trials ongoing and despite all the trials that are being published and collated in very nice systematic reviews like this one in the BMJ, all of those trials are comparing treatments against placebo or against standard of care, but there is no head-to-head trial going on, and we are going to be left out without understanding, for instance, questions like, are all corticosteroids equally safe, or are IL-6 inhibitors more effective than corticosteroids, for instance? Aims and methods. SCYLLA basically aims to understand the comparative effectiveness and safety of treatments given to treat COVID-19, both in the outpatient setting and in the inpatient setting. We have a full study protocol that's now been registered at the European Medicines Agency's hosted NCEP or EU Pass register, and you have the link there. We're going to be using a new user active comparator cohort design with large-scale propensity scores to adjust for observed confounding and negative control outcomes and empirical calibration to adjust for unobserved confounding, all using the OHDSI HEIDS and population level estimation cohort method package. The medicines of interest are going to include all the treatments that have been used for COVID, including antivirals, immune-based therapies, antithrombotic therapies, and concomitant treatments, including antibiotics, cardiovascular prevention, and other concomitant therapies. As I said, we're going to be looking at the outpatient setting and looking at people who started treatment after being diagnosed or tested positive for COVID-19. In this analysis, we're going to be looking at hospitalization as one of the main outcomes for effectiveness, and we have a very long list of additional outcomes that you can see there to the right bottom side of the screen. And we are also going to be looking at the inpatient setting, looking at treatments given whilst inpatient pre-ICU admission, where ICU admission or intensive services is going to be the main outcome, but there are going to be many others as well. Data sources and numbers to date. We're going to be using hospital electronic medical records, GP and ambulatory electronic medical records and claims data in an attempt to look at treatments given as both in and outpatient, as I mentioned. Numbers to date, as you can see, we were going to have quite a large number of data partners who are going to be contributing data, and we are adding up quite nice numbers of participants, users of antivirals, antibiotics, immune-based therapies, antithrombotics, and so on. In the inpatient setting, as you can see, we are also getting quite nice numbers with different data sources, but still quite large number of users of all these therapies. You can see, for instance, how antivirals are close to 40,000 users, antithrombotics more than 45,000, antibiotics more than 34,000. So what have we learned until now from SCYLLA? At the population level, we're looking at how many people are using different medicines. In the inpatient settings, this is an example of something we've just submitted. We are seeing very heterogeneous use of antiviral therapies, with umifenobir being used in China in purple at the top, and no other databases contributing to the study. Hydroxychloroquine with very heterogeneous use of in the different data sources. And the same for azithromycin, lopinavir, ritonavir, chloroquine, oseltamivir, ribavirin, and so on and so forth. When it comes to adjunctive therapies or concomitant treatments, even more heterogeneity, with a lot of use of antithrombotics, anticoagulants, antibiotics, and immune-based therapies, mostly corticosteroids, and a lot of heterogeneity in the different databases. Very interestingly, we also managed to get hold of data on the use of medicines in very particular subpopulations, including pregnant women, as you can see here, with a lot of use of corticosteroids, antithrombotics, antibiotics, and vitamins. And even in children and adolescents, this is an analysis of children and adolescents, people aged less than 18 years old, diagnosed and hospitalized with COVID-19, where you can see not a lot of use of antivirals, but quite a lot of use of steroids, famotidine, and antithrombotics. Now, when it comes to patient-level drug utilization data, we have a very nice web application where you can dive into the detail. You have the link here, and I'm going to walk you very quickly through the main findings. And how this works. So in the outpatient setting, you can basically characterize cohorts of users by choosing cohort characterization on the left, choosing a particular database, a cohort of drug initiators. Here I'm showing you ACE inhibitors. A subgroup, here I've chosen the people diagnosed or tested positive for COVID-19 prior to hospital admission, and then I'm just showing for illustrative purposes demographics. You can also do that in the inpatient and intensive services users. You can also then compare different cohorts, and this is a comparison of dexamethasone users in people hospitalized with COVID-19 in 3 different databases, 2 from the US and 1 from Spain. And you can compare in the same database, but across data, across settings, sorry. This is now inpatient pre versus ICU initiation of dexamethasone in a database here, Premier, where you can see the differences and how, for instance, the ICU users are more likely male than women, whilst in the inpatient pre-ICU, is very balanced by gender. Very interesting visualization as well. You can also compare and choose the plot option and then see the differences between uses of different medicines. This is antivirals in a Premier database where you can see how hydroxychloroquine uses and hydroxychloroquine plus azithromycin are quite different, with hydroxychloroquine uses having a higher prevalence of comorbidities and drug use prior to the index dates. And the same you can do looking, for instance, at two databases like HEM and Optum in this particular example, where you can compare dexamethasone and prednisolone or tocilizumab and prednisolone, and you can learn a lot about this data by just looking at these visualizations. Finally, a call for participation. SCYLLA, as I said, is a multi-headed monster that's going to be massive and it's going to require a lot of work, but it's also going to be, I'm sure, very productive, and it's going to be a massive source of information and learnings. If you want to join the team and help us fight this monster, just email me at the email here. Thank you for listening, and I look forward to collaborating with all of you.
Hi, everyone. My name is Noémie Elhadad. I'm an associate professor at Columbia University. And today I'm going to be talking to you about HERA, large-scale characterization of health equity. So the concept of health equity is one that's been around for a while, and the basic idea is that we, when we strive for health equity, we mean that everyone has a fair and just opportunity to be as healthy as possible. I like this definition given by the Robert Wood Johnson Foundation. And there's often this type of pictorial representation to really explain the concept behind it, where on the left of your screen, you can see what equality is, and on the right, what equity is. And this is really this concept is relying on dimensions from ethics of fairness and justice. This is something we're striving for, but most of what is happening right now is that there are a lot of health disparities in healthcare. And what do we mean by health disparities is the fact that different groups of individuals are experiencing different outcomes in their health and healthcare. And there are a multitude of reasons to why this is happening. I'm giving here a quote from Healthy People 2020 that is giving you some of the factors that might be explaining these health disparities: race and ethnicity, sex as a biological variable, sexual identity, age, disability, socioeconomic status, geographic location, as well as gender. I think there's a lot to say about health disparities, but the one thing that I think is hopefully coming out of this quote is that health disparities are very often multifactorial. I'm putting here, if you're interested, a few citations of seminal papers that are talking about, in particular, racial and gender disparities. Most of them are with a focus in the US, but there's a lot of work outside of the US as well. The second point I'd like to make about health disparities is that intersectionality plays a role. And so intersectionality is this idea that, if you combine race and gender, for example, you might even find even more disparities. And so in other words, these factors kind of compound on each other to drive even worse outcomes for individuals. So why do we care about this? Especially, why do we care about this in the context of OHDSI? So there's been a lot of work in health disparity research. On the left of your screen, I'm showing you in red, what you might have seen as a typical curve of all publications published in the past 45 years. And as expected, there's more and more biomedical research being published. What's interesting here to me is that even though research has been published on health disparities for a long time, there's been a steady increase in publication, and more recently, in the past 5 years, a very steep increase in interest in health disparities. So what's the opportunity for OHDSI? You just heard about CHARYBDIS and a study about COVID-19 and gender and racial disparities. I believe that it's not only about COVID-19, even though that was a particularly striking example of health disparities, but that observational health data are a particularly valuable source of information to study disparities. So what type of question would we like to answer? We'd like to characterize these disparities in health, but also in healthcare across different cohorts, across different subgroups, say racial and gender makeups, across different outcomes, across different databases and countries to look for commonalities and differences. And so that sounds a lot like a large-scale characterization question. So the vision is that this large-scale characterization is the first step toward advancing knowledge of health disparities, but ultimately reducing them. The OHDSI community's input with phenotyping and adding databases to this HERA, to this project, HERA will support generating hypotheses across a wide range of phenotypes and subgroups, identifying conditions under which the subgroups' differences must be mitigated when we're thinking about predictive model and causal inference, and finally, hopefully help researchers detangle the biological differences from the potential implicit healthcare biases. So I'd like to introduce to you this new project that I'm really hoping is going to rally the OHDSI community to think about equity and health disparities. The project is called HERA. It stands for Health Equity Research Assessment, and it's available at this URL. We have just started. We have 10 databases, and we're looking at gender, in particular male, female, and race, in particular Black and white disparities. But my hope with this presentation is that you guys see the potential here and join the journey. So I'm going to tell you two stories. The first one is to characterize the population level between race and gender differences. And we're going to be looking at a cross-sectional analysis of individuals in 2017. In this case, we're looking at people with at least 3 years of prior data. And the second story I'm going to give to you is focusing on a specific cohort, a specific phenotype, in this case, patients with Crohn's disease. And we're going to be looking at the disease of burden, basically, across different subgroups. Again, we're just starting here, and we're really hoping that you see the potential of HERA here. I'm showing you here a live demo of our HERA characterization tool and how it stands currently. So we're focusing on a single database here, which is Medicaid. Overall, so far, we have about 20+ million patients. There are many more in OHDSI, so again, we're hoping you join us. And in this case, we're looking at people who are between the age of 20 and 29. And I'm interested first in comparing the prevalence rates between male and females in that type of cohort. So all people in 2017 in Medicaid that have 3+ years of data prior to it. And I'm in particular here looking at all condition codes that are being prevalent for this population. What we're showing here in this dashed line is kind of like the equality line. And so anything that is above is basically hinting to us that there is a higher prevalence in one group compared to the other subgroup. And so we can go and look at some of these questions. Here we have pain, which is one of the conditions that is very, very much more prevalent for female than it is for male. And you can see here that there's a set of conditions that are very specific to females, so pregnancy, disorders in pregnancy, etc. We also have a way to look at the tables equivalent, and we can be trying to get a sense of what is very much more prevalent in males. In this case, we have things like intellectual disabilities, autism spectrum disorder, etc. But if, on the other hand, we look at what is more prevalent in women, we find, of course, what we mentioned, some of the female-specific type of questions, but also some conditions that don't make sense to be so much more prevalent in women than they are in men. So this is for people who are aged 20 to 29, and we can, in this case, the cohort has been split by age deciles, and so we can, for example, go and look at 50 to 59 years old. And so here, comparing the male and female in Medicaid, we find, again, just by looking at the standard difference between these two subgroups, we find that there are some conditions that are way more prevalent for male in this case than they are for female. If we go back to our plot, we find again that on balance, most of the conditions are above the dashed line. Here I'm showing you a cohort view, and so these are some of our phenotypes, actual phenotypes, not conditions, for which we have that are part of our phenotype library in OHDSI, and we have 100+ phenotypes right now. This is one place where we want more OHDSI partnership to have even more phenotypes available in the phenotype library. But then again, you see that there seems to be a disparity here where female are more prevalently presenting some of these conditions. The second story I want to tell you is thinking about one of these particular phenotype and drilling down into this particular question here. So we're going to be looking at patients with Crohn's disease and different subgroups. So here we're following a particular cohort of Crohn's patients. We're still looking at the Medicaid database. We have about 8,000 male, 15,000 female who have Crohn's disease. And what I'm showing here is 1 year prior to their diagnosis, what are the conditions that these individuals are being reported with. And again, you see this very high prevalence here of conditions for female above the dotted line compared to male. We can go look at the table, but I'll leave that to you. We can also try to think about the burden of disease after they are diagnosed with Crohn's disease, and there's again the same pattern happening. Some of these concepts are particularly prevalent for women versus men. Here you see the concept of inflammation in particular, and we can keep going into some of those as well. What's an interesting question for us at this point is, what happens if I want to instead now be thinking about comparing at the racial level? So I've just showed you men versus women. Here I'm showing you Black versus white. And again, we see this pattern where there is definitely disparities between Black and white individuals with more disease burden prior to diagnosis on Black people. Thinking about this concept about intersectionality, we can try to drill down, for example, between Black women and white women and see that even within the female cohorts, the female subgroups, there are clear racial disparities with, again, seeing a few more conditions being available and prevalent for Black female. So again, the vision for us is that large-scale characterization is a first step toward advancing knowledge of health disparity and ultimately reducing them. I've shown you one very short example of what we could be doing looking at a particular condition like Crohn's disease, but we have hundreds and more of these type of phenotypes where we can study and drill down even more into these different racial and gender disparities. We think that health disparities are a huge problem, and we think that OHDSI can play a major role in reducing them. Are you in? I hope so. We need you. Thanks.
I hope you've enjoyed this plenary session and are as impressed as I am about the tremendous progress that we've made as a community. You know, as much as I'm excited about our scientific innovations that we've seen this year, I'm even more excited about how we've demonstrated how open collaboration can happen and how we can bring together researchers from around the world to collaborate together to solve some of these pressing public health questions that are facing us today. That's why it's critically important that we use this Odyssey Symposium as an opportunity to network and collaborate with each other, to find connections and shared interest, and figure out ways that we can work together to develop common solutions. That's why I hope that you'll join me in our next session, which are network breakout sessions organized by various topics that provide an opportunity for you to engage with fellow collaborators in our community, to discuss topics of shared interest, and to try to make progress towards figuring out what our next collaborations may be. Thank you for joining the journey. I look forward to seeing you in our network sessions.